right.
Dr. Devos.
Hi.
Oh, Angela, do you still have the live stream on?
Music.
Yeah, that's. You need to close the tab with the YouTube thing on. There you go.
Okay.
Yeah.
All right. So welcome back with us, Dr. Angela, Servis, and Felix. Hey, welcome, guys.
Hi. Thanks for having us.
Yeah, thank you for having us.
And welcome back to all the viewers watching. All right. We have a 1 hour live session Q&A with these great guys from the UK. So welcome. How are you doing?
Yeah, very good. Thank you, Stephen. How are you?
So you're both working at the Eden Clinic, right?
That's correct.
That's right. Plymouth.
Great. So for everyone watching the UK, you will find the link to the clinic in the description of this video. So let's start out with some questions I already received in advance. Somebody wrote lots of contradicting opinions about HCG along with TRT. Regardless of fertility and the desire to have kids, generally speaking, is it a good idea or not, and why? Who wants to start?
Yeah, I'll jump in on that one if you like. So yeah, it's a big debate, isn't it? So you'll anecdotally, when you work clinically, you'll see patients that get on great with HCG, and then patients that do not tolerate it well at all. And now, in terms of its efficacy, I know they said, they didn't really mind about sort of fertility or having kids or anything like that. There are other benefits if you are able to tolerate it well. So there's the preservation of testicular volume. So it can have a preventative effect on testicular atrophy, which obviously is something that is seen on testosterone monotherapy. But it also can confer benefits in terms of psychological well-being. So you'll see people say that they feel just that little bit better, or they sometimes refer to it as that missing piece of the jigsaw. Where they just feel sort of better on TRT when they add in HCG. But then, on the flip side, you will get multiple patients that have horrendous anxiety, and you'll eliminate any other factors that you can. And then finally, you'll remove the HCG, and that seems to sort things for them. So it's, in terms of the evidence, it can be beneficial for lots of reasons, but not all patients tolerate it well clinically, in our experience, I think. What about you, Angela?
Yeah, no, absolutely. I think it's really interesting. You made the point about, for some people, it's the missing piece. You very rarely find a patient who's on the fence about HCG. It's either been utterly awful or really good. And there's not really many people sort of in the middle about it. But for me, some people that I would be more cautious about it would be people who's struggled with significant anxiety in the past, because actually anxiety does seem to be a feature if you're going to experience side effects post HCG, one that seems to sort of stand out. But yeah, like Felix says, it's sometimes it can actually end up being the missing piece for some individuals. So
yeah, but trying to say is it a good idea, I think is very patient specific. Like you'll either get on well with it or you won't.
Yeah, absolutely.
Mm-hmm.
Yeah.
And a bit of a related question is, a friend of mine is on TRT, and he is now planning to have kids. And where he lives, that's in Senegal, in West Africa, he cannot get HCG. So he asked me, what are your opinions on Clomid for fertility in men that are already on TRT?
Yeah. So it certainly has a lot of data and a lot of literature behind it to say that it is efficacious in increasing FSH and LH synthesis, even if you are on TRT. However, there's certainly, I think, if you're going to go down that route and you can get it, I would say that because Clomid is otherwise known as clomiphene, but if you can get N-clomiphene, because it's the zooclomiphene part of it that actually makes it more efficacious. There was a study in 2023 that looked directly at Clomid, so clomiphene citrate versus N-clomiphene. And it was a fairly small study. It's only had about 50 guys in each arm. But the guys on clomiphene, rather than clomiphene citrate, had significantly higher FSH and LH synthesis. So, you know, it's definitely something that if you can't get HCG, is something that can be utilized. But clomiphene is much better. And the ocular side effects of clomiphene are slightly reduced compared to clomiphene citrate. So you can get some quite nasty ocular side effects or eye issues if you don't dose clomiphene citrate right.
And it's worth thinking about the fact that the eye issues can be permanent as well. So it really is worth weighing up. And there's also the consideration of raloxifene as well.
So any selective estrogen receptor modulator is going to have the impact on the pituitary to restart it into secreting those gonadotropins again. But raloxifene is a good shout. You know, if I had the choice between raloxifene and clomiphene citrate, I'd pick raloxifene.
I don't know how much of a cost difference there is, or an availability, or if there's any availability issues there either. But yeah.
Yeah, and what is your kind of fertility protocol for someone who is already on TRT and wants to start having kids?
Yeah, so you want to go,
Angela? So, and I might start with a lower dose of HCG. Depending on the patient, it might even be 250 IU 3 times a week, see how they respond and how, you know, whether or not they develop any side effects from it. And see how they get along with that. I also think one of the things that I would say to people considering starting TRT is consider a semen analysis beforehand. And they don't necessarily need to be the more expensive and slightly inconvenient ones that you need to sort of go along and provide a sample for in the hospital, and, you know, with a very short time frame to getting it to the hospital. But sometimes you can buy just the cheaper, the £20-25 from your local pharmacy, and just do them at home. And that won't give you all the details that you get from the more detailed samples that you can give, but they will say, yes, everything's fine, or no, there's an issue, because it just gives you a little bit more information before getting onto TRT, where, you know, there potentially could be changes to your fertility at that point, but it will give us a bit more information to get on with later on down the line.
Something
Sorry, Felix, go on.
Yes. Sorry, Angela. Yeah, something just to add to what Angela was saying, something I've used in the past for guys that, you know, I very much will echo what Angela's saying in terms of using the lowest effective dose for the maximum outcome, and then I'll titrate that up in terms of HCG, and I've added in recombinant FSH as well. And that tends to, you know, there's a couple of well-known brands of mixed sort of recombinant FSH and HCG. There's things like Menopure. Gonal-F is one that I've used with success in the past, and that's recombinant FSH, and that has significantly improved parameters, which sort of reached a threshold with HCG at sort of 2,000 units in a week for one specific patient I remember treating. But it's so there's lots of options. So if you are a guy out there who's been on TRT a while and you decided you do want children and you haven't frozen any sperm, then there are options, and I think the key is just using them in a staggered approach. So we try to as much as possible avoid polypharmacy, as in using multiple drugs when you can use one for the same end. But there's a staggered approach to doing it, and there's lots of options. But recombinant FSH can be added into HCG as well.
Also, I think
is it available in the UK?
Yeah. So Gonal-F is something that can be prescribed privately. You'll be very lucky to get it in the NHS unless you have exhausted all other avenues and you're under a fertility specialist. But it's something that can be obtained. There's usually supply issues with these things because a lot of it gets ring fenced for NHS supply. So and then they decide who gets it. But it is certainly something that I've managed to get hold of in the past via pharmacies.
I think with the HCG as well, sort of knowing, and it's very much patient dependent on whether or not they're prepared or feel better taking lower doses daily as well. And sort of titrating the dose gently, I think, is usually the better way to go, but also being mindful of what it's going to do to testosterone levels. So sometimes bringing the testosterone dose down as well, to sort of accommodate for the HCG as well. So, but it's very specific to the individual. And that's one thing that I tend to find, there is no one size fits all. And, you know, sort of prescribing the same thing for different guys and expecting the same outcome just doesn't work. You know, which says to me that there were so many variables out there that we probably don't fully understand, which again is why it's really important to be sort of cautious and take things gently and try and change one thing at a time rather than throwing lots of things in, because it doesn't usually necessarily get you a fast result.
Yeah, more is not always better. In fact, that's pretty much the mantra I live by in TRT.
Yeah, sure. So I'll take the first question there in the chat box. Ever since starting TRT, I have struggled with super high triglycerides. Any suggestions on best approach? Unfortunately, allergic to fish oil, so fish oil is not an option. Could it be the TRT?
No.
It's unlikely. No, it's unlikely to be the TRT. I think I would be looking towards body composition and finding out a little bit more about that. And thinking about BMI, not necessarily BMI, but more body composition. Actually, I'll stick with the first answer. And if you can potentially reduce body fat, if that is an issue for you. And also, when you say super high, I would be wondering how high and whether or not there was any other derangement in lipids as well.
Yeah, so like, I think that's a good point, isn't it? It's like, you know, familial hypercholesterolemia. I want to look at a metabolic panel as well. Like, you want to know what their insulin resistance is like, because there's a negative association between triglyceride and glucose and body mass index and actually testosterone in men. There was actually a study done last year that looked at exactly this, and it showed that people who had very low testosterone had high triglycerides. So if you're on TRT and you're normalizing your testosterone levels, it's very unlikely that it's the testosterone causing your triglycerides to rise, because it should actually, it would be high in someone who was hypergonadal. So yeah, I don't think that's it at all. But yeah, I think certainly looking at insulin resistance, what their diet's like. So the number one thing that will raise your triglycerides in the UK is either going to be high glycemic index diets or alcohol. So you'd want to look at all of those things.
Sure. Next question is about Primo, but we won't be taking PED questions.
No. That's not TRT.
No, yeah. Then another question there. I eat garlic every day. I recently read about garlic thins the blood. So would this help with keeping my hematocrit lower? What can you say about that?
Yeah, I mean, we've literally just done a video on hematocrit on our channel. You don't need to worry about that. It's you're going to have a slightly elevated hematocrit being on exogenous testosterone, but it is not in any way linked to increased risk of thrombotic events. There's many studies out there on this, and one that we even talk about in the video, which we'll probably try and throw a link to somewhere in this maybe. Yeah, it's not something you need to worry about.
I think it's worth sort of unpacking a little bit, I suppose. So we're smiling about this because it's a question that comes up. It comes up quite a lot. And actually, when you see hematocrit going up, it's actually a sign that the testosterone is doing its job, and it's actually sort of helping improve your blood profile and helping you sort of create more red blood cells, which is a good thing and will help from a from a health point of view anyway. When people talk about hematocrit being elevated and associated risk with sort of clotting events, there's other conditions that cause problematic elevations in hematocrit, and that's what everybody gets a little bit concerned about. So actually, because of the process that's making the hematocrit go up for patients that are on TRT, so long as they don't have any other health conditions, this isn't going to be an issue with them. So polycythemia vera does cause an elevation in hematocrit, and this is concerning because it also gives you platelet dysfunction, and that's what makes the blood sort of aggregate and coagulate, and that's what puts those people at risk of clotting. So yeah, but fascinating about garlic thinning the blood, not something I'd heard of. So But yeah, from that point of view, you know, so long as the reason for your hematocrit being elevated is your TRT and there's not any other concern, it wouldn't be something, when you don't have any other risk factors, it wouldn't be something that you'd be needing to treat.
Yeah. Another question. Hello, I am 46-year-old. I had 2 testosterone tests. One was 316, one 312, almost the same, with low free testosterone. Would I be a good candidate for TRT?
Yeah, I mean, it depends. You need to look at these. We need to be careful about not looking at numbers in isolation. So if you know, there's lots of sort of, you know, popular YouTubers out there talking about this at the moment. Actually, it's quite a hot topic about having low testosterone and just knowing that you have that because someone suggested you test it. But then these people are actually functioning very, very well and at a high level, and, you know, in terms of being athletes. So numbers in isolation are not something that should trigger you to say, oh, I found this number looking like this, I should change it. You need to decide whether that is in conjunction with qualitative symptoms such as, you know, fatigue, reduced libido, inability to put on muscle, lack of motivation, anhedonia, things like that. It's something that I like to get to focus in on in just numbers. We need to look at everything as a bigger picture.
I think it's also worth thinking about your state of health just prior to having the blood test, and this may not particularly specifically relate to you, but, you know, some people might have had poor health or ill health due to other reasons and thought, oh God, maybe it's testosterone. So they go out and they go and get checked. And actually, you know, there are other causes, and you sort of zooming in on testosterone when actually there might be another health illness that's going on that's actually causing a reversible health illness that's causing the low testosterone. And actually, if you treat that reversible cause, then that will resolve. Because, you know, TRT isn't, you know, it's a commitment. It's lifelong. For many people, it's something that they end up having to pay for privately. And, you know, I get guys all the time being like, oh, yeah, no, that's totally affordable. That's fine. But that's fine for you right now, here and now. And life changes and life circumstances change. And, you know, knowing that your forever you is going to be able to manage this independently financially, you know, is different as well. So if there are reversible causes, if you took your blood test right after you'd had a short burst of an illness or whatever, your testosterone might be down. So it's just worth bearing in mind all those bits and pieces. And like Felix says, actually, how are you feeling is the biggest thing. And I think I open almost every consultation, whether or not it's a review or initial consultation. You know, once you've done the niceties, it's always, how are you feeling? What's going on? And that's really, really important. It's such a big gauge for, you know, really getting to the bottom of how someone's hormonal state is really affecting them.
But even if someone is not experiencing low testosterone symptoms and you find randomly these low testosterone levels like 250, 300, health-wise, wouldn't it be better to bump those up to 600, 700? For longevity and health reasons?
There definitely would be cardiovascular benefits for sure. Yeah. So because we know that there's an association with being hypogonadal and having an increased risk of deleterious cardiovascular events, and also an increased risk of neurological events such as dementia and Alzheimer's and things are associated with low. So yeah, I can see the argument for it, but I guess that has to be context specific. If you've got a young male who's yet to have a family, who's 25 and he's an entrepreneur and he's, you know, very muscular, going to the gym, and he just happens to have bloods that are 250, 300 total T, then you know, you could argue maybe you've got time to wait for him to finish having his family and things if that's in his plans, and then look at it again later. But yeah, I think it's very context specific, and you need to look at what the actual picture is with each patient at the time.
Mm-hmm.
And like I said, those reversible causes are really, really, really important. And sometimes you won't necessarily know the reversible causes, but they might be the ones that you kind of want to say, let's recheck again in 3 months or 6 months or whatever as well. Give them the information, because with all of this stuff with testosterone deficiency, it tends, like I always say, this is a marathon, not a sprint. We don't need to start it off straight away, taking that time to talk about things if you're in a relationship as well, so that you know, you can talk it through with them, so you can make those big decisions that you kind of feel like you're almost being forced into doing super quickly. But yeah, absolutely, Stephen, you make a really good point. Even if you're not necessarily symptomatic with that testosterone deficiency, it's still worth considering all the other things that Felix rightly pointed out that you can prevent, even from a sort of a metabolic picture as well, sort of metabolic syndrome, and thinking about, again, body composition and fatigue and mental health as well, which is really important. So if your numbers are low but you feel okay, you know, you might want to choose to monitor it for a bit and see how things go, check out the reversible causes process, and then go from there. That would probably be my
something
advice.
as simple like, you know, we've seen this before, like something as simple as someone constantly being in a caloric deficit to maintain a level of leanness will make them hypogonadal. And as soon as you start eating maintenance calories / a little bit more, your testosterone normalizes. It's you know,
shift workers who are doing night shifts or really long shifts and things like that. It can be a post-viral, you know, post-viruses, post-COVID and things. It can really kick around and ditch the testosterone for quite a long time. So there's so many variables that can impact it. And I think the British Society for Sexual Medicine recommend at least 2 blood tests, sort of proving low by their standards, TRT. Before providing TRT. And I think that's really, really important, because it's a snapshot. You can take it different times of the day and you'll get different pictures. But if, you know, if the only phlebotomy appointment someone can get is post, you know, 7 night shifts on the trot, then actually it may well be low anyway.
He just added, I have chronic insomnia, a big belly, and osteoporosis. I have an appointment with an endocrinologist on Tuesday.
Okay. Yeah. I mean, yeah. So take the guidelines with you to speak to that endocrinologist, because you know, there's not all endocrinologists created equal, is probably a way of putting that. Like, some people that have specialist interests in TRT will be good, but if they don't, then it may be an uphill battle. But yeah, just make sure you're well informed.
Yeah, I think they seem to run by a different set of thresholds for treatment. So, like I said, we generally run at Eden Clinic. We run through the British Society for Sexual Medicine, and you can actually Google their guidelines, and they give you the treatment thresholds for both free and total testosterone. I hope that's helpful.
Probably when you go the insurance way, they will only look at numbers, and if you're not low enough, you won't get treatment, right?
Yeah, that's certainly going to be a factor for sure. If you use health insurance, then health insurances are businesses and they want to make money rather than give it out.
Yeah.
Justin asks, I'm currently on 200 milligrams testosterone a week, split twice a week. I feel this dose is close, but thought asking my doctor if she could bump it up to 250. Is that considered a big jump?
I mean, it's an interesting one, isn't it? So I am assuming that this patient is in the States. So in America, there's quite sort of a blanket approach of a starting dose of around 150 to 200 milligrams per week. Whereas in the UK, you'll find that most practitioners and clinicians will start small and titrate up, which is what we're taught to do with all medicines, really, because you want to look for the lowest effective dose for the maximum outcome, rather than starting high and then going down. Because you know what you end up doing that way is you can get large amounts of negative treatment effects, otherwise known as side effects, when you could actually minimize that by using a titrating up manner. So I would say, to answer his question, 200 milligrams, if he's feeling good on it and he's not having any negative treatment effects, then I would stick with it. Like, bumping it up just because you want to see what will happen might end up being negative for you rather than positive.
Perfect. And I think also just having a think about what, you know, are you wanting to increase it to see whether or not you can feel better, or are you wanting to increase it because you have specific symptoms that you feel are attributable to testosterone deficiency and that you feel aren't being managed by your current dose? And then kind of trying to unpack some of those symptoms and see whether or not there are any other causes. So I think sometimes libido is a really big one that people say, oh, my libido is still not quite there. And then you kind of talk about things. It's like, well, how's the relationship? Or, you know, if they're not in a relationship, actually, how's the stress? Are there other factors impacting that as well? So Erectile function, again, is another one that sometimes people say that's not quite there. And actually, sometimes, if that's the only thing, then actually introducing something like a PDE5 inhibitor, like tadalafil or Cialis, can be really helpful and have less side effects. And actually, a medication like tadalafil or it can actually do loads of other positive things, like reducing cardiovascular risk factors, and actually have those positive things as well. So it's kind of about trying to understand, you know, what's your motivation for increasing that dose, and making sure that actually that's the safest thing to do and the most beneficial thing to do for you, and just double check that there's not something that's going to be better for you.
Next, I'm on 100 milligrams scrotal cream applied in the morning. I still have symptoms. My doctor won't increase the dose because he said the testosterone needs to be under 30 nanomoles or my estrogen will be too high.
Good.
Yeah, I mean, we're laughing because, yeah, there's so much to unpack here. So for starters, focusing on the number and keeping it below a certain level is a little bit unnecessary. I get that people have a high threshold because they look at inferred evidence from studies that were done on bodybuilders using large amounts and then ending up with cardiovascular remodeling. So things like left ventricular hypertrophy, and then they infer that evidence in a dose dependent manner. Which doesn't always equate, because everybody has a different genetic set point as to what level of testosterone will cause them harm. And there's no way of us testing for that. And that's to do with things like, the amount on a genetic level, like the amount of CAG repeats you have. That's a whole other rabbit hole altogether that we could talk about for hours. But that's the first thing, is the numbers thing is something that needs addressing. And then the estrogen, I mean, there's so many videos just on your channel, Stephen, on many others. Andrew Winge of Man Medicine recently did a video about it, and he quoted a paper that I really, really like from the Journal of Endocrinology, that very, very succinctly stated why using estradiol from a serum sample is almost next to useless in terms of how you can measure risk. And I get why. I get why some clinicians are worried about estradiol, because there's like everything, there's a little bit of understanding and a bit of truth that's then exaggerated into the context of TRT, where it's not actually the correct context to be equating it to, and that's because estradiol is a sort of surrogate marker for arginine vasopressin, or AVP, which is something which is a hormone that regulates our set point for sodium, and then things like renin and aldosterone come into play as well. And they're what regulate our renal free water. So it's that little bit of that surrogate marker of estradiol being involved in that process that makes people then worry about hypertension or high blood pressure. So that's where that misunderstanding comes from about estrogen causing hypertension. And it's because it's based in a little bit of truth, because it's involved in a small manner in a process of other hormones that do actually regulate our free water, which is aldosterone, renin, and the angiotensin system as well. So it's a difficult one, because when you've got those people that have this belief, they are genuinely thinking that they're looking out for your best interests, because their understanding is that this will equate to hypertension, and that simply isn't the case.
Well, I also think that it's quite a commonly held belief in the TRT world, so to speak, by clinicians and patients alike. And yeah, so it's not going to be that particular individual has much, if you spoke to a lot of doctors about it in or outside the TRT world, then they would have similar thoughts and feelings about it. So as Felix says, they're just trying to reduce their perception of your risk, really, for it. The other thing to think of would be thinking about you saying that you didn't feel your symptoms were controlled. I'm assuming it's one click once a day by the sounds of things. It might be if it's, you know, if it's a particular time of day, if you're thinking that actually by the afternoon you're not feeling so good, then some people talk about getting split doses as well, which might be beneficial to you. It depends. That can get a little bit more pricey because they tend to charge essentially what comes out in the wash as being per actuation. So increasing that dose will essentially almost, well, pretty much double the payments and things. But sometimes they might be amenable to trying to sort of alter the concentration, so potentially you could take it twice a day and that might be beneficial for you. So that's something else to have a think about and see whether or not that's be something they consider.
Yeah, he used 100 milligrams scrotal cream once a day, so that's 2 clicks of 50 milligrams. Yeah, but probably the dose is not enough, eh? Just maybe add 1 click in the evening there and see how that
titrate it up like that. Yeah, always under the supervision of your responsible clinician.
Yeah, absolutely. But I have to say as well, though, I find the dosing of the scrotal creams really difficult to predict because of the absorption is really hard to predict. And I think that's one of the harder elements of those. And for some people, they get on really well with it. And then other people, we don't manage to get the dose sort of steady or stable enough. But yeah.
Yeah, if people want to have a look at that paper, it's called Mechanisms in Endocrinology, Estradiol as a Male Hormone. It's by Nicholas Russell and Mathis Grossman. It's very, very, very interesting read.
Do Subq injections every day lower hematocrit over time compared with intramuscular?
I mean, it's the Subq route versus shallow intramuscular or even deep intramuscular. You tend to, this is about absorption rate. So you tend to in intramuscular see a spike quicker in sort of serum testosterone levels and then correspondingly across other biomarkers as well. And it's the fact that you're injecting subcutaneously into fat and its absorption being slower and also it goes through the lymphatic system a little bit as well, that will give you this sort of false impression that it doesn't elevate things as much. And that would include how quickly your serum testosterone levels raise as well. But it will over time because we are always subject to the rules of pharmacology, which is 5 times the half-life of whatever FD you're using. So if you think about cypionate, it can have depending on what sources you look at, you could look at 7 to 10 days as the half-life. You're not going to see its actual effects until 50 days in. You just might see steeper rises in terms of the cumulative curve by doing it via intramuscular versus subcutaneous. And we don't, as we said, we really need to worry about it raising hematocrit fast or at all, really. It's in the absence of other risk factors, like Angela was talking about earlier on.
Mm-hmm. Angela?
Yeah, no, sorry. I wasn't sure initially whether or not the question was about the frequency, but again, the frequency or the delivery.
About the administration route, if Subq is better for hematocrit than intramuscular, but...
Yeah, I mean, that's a valid point there that Angela makes. Like frequency will have an impact on how quickly numbers rise as well. Like if you're doing daily injections of tiny amounts, then you're going to see that there's going to be a slower cumulative curve to getting to peak plasma concentration.
But usually if there is going to be that change, then you're going to see it within the first 6 or so months anyway. But it goes back to that question, that exactly what Felix has just said about whether or not the hematocrit increases of clinical significance and carries any risk, which for the majority of patients it won't, and for those that it does, the issue is not the TRT, the issue is something entirely different that does need looking into.
Low Florin has a good point there. He or she writes, the big problem is that doctors give you antidepressants directly when you tell them you are sad or have mood swings. In my case, the cause was the lack of testosterone. He's male, of course. I found out after the tests.
Honestly, this is such a big bugbear for me, and this is something that you see and hear of all the time. Guys get put on antidepressants, which makes erectile dysfunction worse, which can make them more socially isolated, can damage and challenge relationships and things. And for me, you do a set of blood tests when often patients will have a set of blood tests done when they start going in with symptoms of low mood. Certainly women of a certain age would have a set of blood tests done just to check that there weren't any other causes. And And this is a real opportunity to check these things. It's not an expensive test. But I do think that while it's not an expensive test, we tend to test for things that we know how to manage. And actually, a lot of the time, certainly in primary care physicians don't tend, and this is a broad sweeping statement, but as a general rule, they don't tend to feel comfortable managing testosterone deficiency. So I think that might be partly where the issue is. But I mean, even with people with, type 2 diabetics, we've got an absolute opportunity there to test for testosterone deficiency, because we know that 40% of type 2 diabetics will develop testosterone deficiency, and start looking out for it. They're having regular blood tests anyway, and it's such an easy and really satisfying thing to treat. When you treat it early, it keeps it treats the depression far better than an SSRI, which has limited evidence for anyway, and will, as I said, create even more side effects for that individual, and won't get people back on their feet and back to living good, happy lives nearly as fast, or if ever, as normalizing someone's testosterone for them. So yeah, sorry, my little rant there.
You're right. Our friend Joseph O'Reilly, who asked about the daily Subq injections to keep the hematocrit low, he added something there. He says, "Thanks, guys. I'm just trying to keep my hematocrit and hemoglobin down without resorting to therapeutic phlebotomy." So I think you have to explain something more there.
So
yeah, I would say go and watch our video on the Eating Clinic for Men YouTube channel. We talked about this for about 45 minutes the other day, and we go through a lot of papers that suggest that therapeutic venesection is not the way to go, and why. It's not necessary. It's not necessary.
We've sort of essentially on that video sort of gone through all the reasons about why actually it doesn't necessarily, for the majority of patients, create a health risk, and actually therapeutic phlebotomy or venesection can essentially undo the body's great work of creating all those lovely red blood cells for you. So do check that out. I think also, Stephen, you must have done some videos on this as well. So but definitely worth checking it out. It's great that you're asking the question though, and trying to educate yourself on it. So yeah.
Okay, we've covered the questions that are in the chat box for the moment, but while we wait for new questions, I had 3 more actually, because I know in United States they have their opinions on using the next 3 pharmaceuticals next to TRT. That's as you already mentioned, tadalafil. Then you also have metformin, then for longevity reasons and so on, and telmisartan to keep blood pressure in check. How are your guys' opinions on using these pharmaceuticals next to TRT for health and longevity reasons?
So I think tadalafil, I think, is actually a really, really good medication. I think for guys who are experiencing any erectile dysfunction, for guys who have any cardiovascular disease as well, this is a really great medication. I also urge caution with just treating erectile dysfunction with tadalafil, because I always talk about the sort of the holy triumvirate when it comes to erectile function, and just thinking about essentially brain and nerve issues. So are you stressed? Do you have any nerve problems? And those are really things to sort of consider. Then obviously hormonal problems, which obviously we'd be trying to treat as well. And then vascular issues. Is there a problem from a vascular supply? Do you have vascular inflammation or atherosclerotic disease as well? And making sure you consider all of them. And sort of ask the questions, because if one of those or more than one of those has a problem, then you won't necessarily be able to wholly treat it with a PDE5 inhibitor. But I think the benefit, so some people struggle with some side effects from tadalafil, and they can range from reflux, so acid heartburn. So you can bypass for that by taking it after food and things like that. Sometimes people get a bit of a stuffy nose because they're causing dilatation throughout the body as well. So that's just something else to look out for. And actually for those people, just taking a really tiny dose of half a tablet a day can sometimes resolve those things. The other issue that some people get, particularly if they do a lot of training and a lot of deadlifting and things, can be back bump as well, which is just something else that's just really unpleasant if you don't warn people off about. And again, for me, I'll often say to people, actually start off on half a tablet, see how you get on with it, see if you get any side effects, and go from there. But yeah, tadalafil is definitely a medication that I would recommend. If any of those things are an issue for you. So yeah.
So on the subject of telmisartan and angiotensin receptor blockers in general, it's become very popular, telmisartan, just purely because this was off the back of some studies done a long time ago. Back in 2009, there was a big study called On Target. And then there was the Transcend study as well, which specifically looked at what they would call maintenance dosing of telmisartan in terms of cardioprotection. And they specifically looked at this ARB rather than ACE inhibitors because of its tolerance and safety profile. So because with ACE inhibitors, you can run into all kinds of issues if you take other medications, especially if you're a diabetic, or you have other sort of cardiovascular drugs if you have other cardiac issues. But it's exceptionally good at keeping your blood pressure under control if you are hypertensive in a dose-dependent manner throughout a 24-hour period. That's why they like telmisartan for sort of first-line ARB use. But yeah, the On Target and Transcend studies did look specifically at cardioprotection, so in terms of longevity, and found it to be particularly useful for preventing new onset of diabetes. Type 2 diabetes was one of the outcomes, and also it reduced people that had fast AF or atrial fibrillation, and that was as a direct result of controlling their slightly hypertensive state. So the conferred benefit for it in terms of taking it as a maintenance dose for someone who doesn't have those pre-existing conditions is based on those studies. So it stands to reason that it would provide good cardiovascular protection, and that was found in both of those studies back in the early 2000s.
Mm. Okay. And on metformin?
Yeah, so metformin wise, I think looking at, checking out somebody's HbA1c is also always going to be helpful, and looking at their general metabolic risk profile, and looking at their body composition as well. But it can help with those. Obviously, it can help from if they've got an elevated HbA1c, certainly if they're drifting into the pre-diabetic range. You want to be looking at all sort of lifestyle factors and what people's diets are like, because the other thing is that you want to be encouraging lifestyle changes if they're appropriate, rather than medicating things unnecessarily. And I think there is quite a large group of patients that come to TRT having had a really tough time of it over a really protracted period of time, and kind of using that to really examine and get honest about your commitment towards your health as well can be quite helpful, and using that to start looking at all elements of things. Also considering, yes, metformin does can play a role with regards to management of the metabolic picture for some people who've been struggling with this for a longer period, but also putting together, actually, if you're starting TRT, you might be starting HCG and tadalafil, and adding metformin into the mix. You can end up with, Felix mentioned earlier on about the sort of the polypharmacy element of things, and throwing drugs at a situation that might be managed by diet and exercise that you might find easier to do, can be an extra, it can be an amazing tool, don't get me wrong, but it can be that there are other things to try before adding in metformin. Yeah, I
think just to add to what Angela's saying there, like the main consensus of evidence for metformin is that it does appear to have sort of health span positive net benefits. But that's usually, or it's quite controversial. You can get people arguing for and against the use of metformin in this manner. But it's been shown to reduce sort of the incidence rate or severity of existing conditions like diabetes and cardiovascular disease and cognitive decline and even certain cancers if you look in the evidence. But I think that's all indirectly via its cellular metabolism modulating properties, and that's usually via enhancing insulin sensitivity, which then reduces your weight, which reduces oxidative stress, and therefore gives protective effects from a cardiovascular point of view, particularly in the endothelial lining of blood vessels. But it's all because you're improving that person's body habitus, not necessarily as a direct result of the drug. So I don't think in a dose-dependent manner, having a higher dose of metformin will increase your health span by anything. It will actually just make you exercise more, eat better, and then it has indirect effects in insulin sensitivity. But yeah, there are fors and against, like Angela was saying, of trying to keep pharmacy simple and then actually finding a net benefit from a drug.
Yeah, and I think, like I said, there are so many additional benefits that you can get from starting TRT and normalizing your testosterone with regards to mood, with regards to energy level. And actually, people often find that if they do, if they have been challenged with a body habitus that isn't quite so healthy, often they find the motivation and they get up and go to do the exercise and start eating better and start doing a bit of reflection. Whereas before they've had so much brain fog about them that they, struggle to plan their week around going to the gym and around eating and things like that. But actually, once they feel like they've been getting the help that they need, it really feels like things feel a little bit easier to tackle like that. So yeah, I think I would aim for lifestyle first, and it certainly wouldn't be something that I started people off on. If there were weight management issues as well, I mean, the other thing you could think about would be GLP-1 inhibitors and sort of semaglutide, for example, potentially. But again, it wouldn't be a starting point necessarily.
Sure. Back to the chat box. What are the optimal vitamin D levels for testosterone and men's health?
The evidence of this is again controversial. So you'll find papers that say that there's a direct correlation between low vitamin D and low testosterone, and then you'll find papers that say that there isn't, it's an associative relationship rather than causative. But I think certainly most people in the UK, and certainly those with darker skin, will find that they are not even in optimal levels of vitamin D. So I usually recommend to patients that they supplement at least 4,000 international units of vitamin D, along with K2, 100 micrograms as well. Without the K2, we can't absorb and utilize the vitamin D. But again, you tend to get better micronutrient function by normalizing your testosterone levels anyway. But yeah, certainly trying to be outside as much as possible is useful. But in the UK, we don't get much sunshine, so everyone should supplement vitamin D.
We're certainly not at the moment. Yeah, no, we do find that a lot of our guys, because it's one of the things that we screen for when people come through, a large proportion of them are vitamin D deficient. So, and it's a really easy win as well. So.
Yeah, and what levels are you shooting for in the blood? Because I know here in the laboratory where I send my patients to, they are already happy when it's between 20 and 40. But I know some American guests I've had over on the channel, they are happy with 80, 100, or even 120 in the blood. What are your labs saying?
I think it depends on what the unit of measurement is. Yeah. So because this is where we fall foul with the nanograms per deciliter and nanomoles per liter that we have with testosterone. So yeah, I would say in the UK we tend to use nanomoles per liter. So you'd say like optimal would be sort of 75 plus, but yeah, adequate would be classed as 50 to 75. But yeah, and then deficient is so then there's two tiers for the low level. Actually, there's insufficient and deficient. Yeah. Insufficient is 25 to 50, and then deficient is below 25 nanomoles per liter.
Okay. All right. Let me get back here. Can you talk about prolactin levels and how higher or lower levels affect males?
So prolactin varies a lot and will vary due to stimulus. prolactin level, it's really unhelpful actually, because certainly on Medicheck's lab ranges and things, or not just that particular company, but a lot of them will sort of show red, and people will come in terrified, having Googled high prolactin and come up with prolactinoma. But actually, stressful events can make prolactin spike considerably throughout the day, and it will fluctuate, within a few hours according to any stimulus, or it might be stressful stimulus, it might be sexual activity as well. So yeah, it depends. And I think if you have a elevated prolactin that you're concerned about, waiting and repeating the test is usually the most useful thing to do, because if it's of a concerning origin, like a prolactinoma, that's a tumor that arises in the pituitary gland, which is in the brain. If it is that, then it will remain elevated. Whereas if it's due to stressful stimulus, or sort of an acute stressful stimulus or anything, then it will, it will reduce again, and the next test will come back reassuringly normal. But the fluctuations are really significant and regular. Sort of within a few hours, you can get those changes.
And that's completely normal. I would say that if you have accompanying symptoms such as prolonged headaches, and you are serially monitoring your prolactin, and it's in the thousands, like that's something that needs to be checked out for sure.
Mm-hmm.
I have a low SHBG and suboptimal testosterone. Should I try to increase my SHBG before starting TRT?
SHBG is a really interesting one. So there's, if you look at stat pearls on PubMed, there's actually an entire entry about SHBG and how complicated it is. Now, if you have and always have had a low SHBG, that might just be a genetic transcription that you have. You have a polymorphism for having low sex hormone binding globulin, and which is a shame, because sex hormone binding globulin is a positive health marker. So you want it to be in sort of the mid to upper ranges, but not too high, because it has so many different functions. So if you have suboptimal testosterone levels and also low SHBG, that's not a great combination to have, and is something that I think you'd struggle to actually increase, and unless you'd ruled out other things, because there's a very strong correlation between hypothyroidism and low SHBG. So you can sometimes correct people's hypothyroidism, or rule out things like Hashimoto's disease and start them on combination thyroid therapy, and their SHBG may increase. Now, if your thyroid function tests come back completely normal and your TPA antibodies are normal, therefore ruling out Hashimoto's, and you're still low SHBG and low testosterone, then I think probably TRT might be beneficial. But you'd have to take that in the context of the rest of your exam as well.
Mm-hmm. Any natural ways or things you recommend to increase SHBG?
Eat enough. Like, yeah, so people don't eat enough. Like, there's a strong correlation between metabolic health and SHBG being high and low. So yeah, if you're constantly starving yourself to stay lean, that's not going to have a good impact on your SHBG profile.
Okay. What are your thoughts on men taking progesterone cream while on TRT?
I mean, were you deficient in it in progesterone in the first place? It's like, yeah, I get where people come with this, because they talk about sort of neurosteroid suppression from taking exogenous testosterone. But if you had no symptoms and you didn't measure the number, I wouldn't suggest adding something in without having a reason for doing it. It's like Dave Lee says. It always reminds me of that. If you have a cocaine deficiency, you wouldn't go out and just do a line of cocaine. Like, it's just, it's something that if you've measured it, but you didn't have any concerns about it before, and then suddenly you know the number, but you still don't have symptoms, then why would you bother supplementing that? Because the thing with progesterone is that then leads to progestogenic cascade effects downstream, and that can often lead to other things not being great. That can have an impact on your psychological well-being, libido as well. Progestogenic effects can also precipitate people who are genetically prone to gynecomastia. Contrary to popular belief, it's not estradiol that tends to cause gynecomastia. It's usually progestogenic effects or genetic predisposition. So yeah, I wouldn't bother supplementing something just because you found out it's low, unless that was accompanied with symptoms, in my opinion.
Mm-hmm. Do you guys often prescribe pregnenolone and DHEA in your practice?
It's certainly not something that I regularly prescribe.
I have done in the past, but yeah, not routinely.
Okay.
No.
You're not even measuring in the labs?
Not routinely, no. Like if you've got symptoms that you've exhausted other avenues and looking at blood profiles, we might look at progesterone and DHEAS. Yeah, and then look to I try to modify everything else first, and then if you then look at those levels and they are deficient, then I think trial of supplementing those is not out of the question at all.
Yeah, okay. Because I know a lot of people, even here in Belgium, they tell me out of the blue, yeah, I'm taking DHEA for anti-aging purposes. They tell me for their skin and so on. They can get it in Holland over the counter, DHEA tablets, even if they are not on TRT, they just take it for their skin for anti-aging purposes. So.
Yeah, and it has mood modulation and stress decrease. It modifies cortisol levels as well. So yeah, I can see why people would do that. I think like with everything, exercise caution in terms of dose if you're doing it without supervision.
Could it have a negative effect on testosterone levels, just taking DHEA for no reason at all?
It shouldn't do, because it's not a suppress it. It wouldn't suppress your hypothalamic pituitary gonadal axis. It's certainly a downstream hormone in that process of the steroidogenesis cascade. But it certainly shouldn't suppress your gonadotropins, which would then directly impact your testosterone synthesis.
Okay.
So even when you said people are buying it over the counter, is it only skin symptoms that they're treating? Are they testing first, or are they just buying it for sort of a skin rejuvenation treatment?
Yeah, they're not testing it. They just read DHEA is good for anti-aging, for skin, to fight wrinkles and so on, and they just buy it. In Belgium, it's impossible, but yeah, in 30 minutes we're in Holland, so there you can buy it over the counter, and yeah, I know a lot of people are taking it for their skin. They tell me so.
Interesting.
Yeah, well, that's the internet, really. People read a lot of stuff. People are asking me about taking all kinds of things like collagen and hyaluronic acid supplements, all things like that. People take a bunch of stuff for their skin as well.
Yeah.
Okay, I see we're just almost 1 hour in, and we've covered all the questions. So maybe to close this up, talk about your clinic, Eden Clinic. Where is it, and what do you guys do?
Awesome. Yeah, so Eden Clinic for Men is in Plymouth, which is in the southwest of England. We treat people either in person or remotely as well. So we can treat people via video link that are in the UK. And we hopefully support men with testosterone deficiency. And also we help with weight loss if that's something else that needs to be done as well. So if people did want to come in and have face-to-face meetings, then they can do. But like I said, we can manage patients remotely as well.
And can you treat men from abroad, from Europe, from Belgium?
Currently, we can't, but it is something that we're looking into.
Probably difficult, the laws, because you're not even in the EU anymore.
Exactly, which does add challenges, but part of it is insurance. So it just adds multiple complications, really, which is a shame.
Yeah. Well, there are more possibilities in the United States. I see a lot of them are doing telemedicine for a lot of states, and here we're just these tiny countries, and we all have different laws. Yeah.
It's interesting actually when you see some of the American providers talking about which states they can and can't provide for, and I wasn't aware that was an issue until recently. So yeah, they
have to have a license per state. I've learned from them. So some can do a lot, some can do only one state.
Yeah.
Okay, so let's finish this. So I'm gonna thank you both for your time and for your sharing your knowledge. I'm sure.
Thank you for having us.
learned a ton, and people watching after this has been live afterwards, they can still rewind this and learn as well. So thank you again, guys.
Thank you very much for having us,
Fantastic.
Stephen. Take care, guys.
So
Yeah,
all the best and have a good evening. Bye-bye.
Bye.
Bye-bye.
Bye-bye.